Thank you very much. So it's been great to see the other presentations, and there's been some comments just between the presenters that it's been nice to see how all of our presentations kind of meld together into this continuous education around how to move forward with EDI within this space. We've heard a lot about why EDI is important, the hows of EDI, stories behind explaining our own bias and the ways that we exert that bias in ways that maybe aren't the most healthy. I'm going to talk a little bit about social innovation and how, as we try and make change within these areas, often we experience pushback. We experience struggle as we try and achieve the change that we're all hoping for, and hopefully to provide some advice that'll be helpful on what we can actually do about it. So who am I? I was born and raised in the Métis homelands in Treaty 4 territory of Southern Saskatchewan. I have Métis as well as Cree and Anishinaabe ancestry. My mom's a Pacific Islander. She's from the island of Tonga. I've had lots of experience in the area of social innovation at local, provincial, and national areas. Had the great opportunity to be part of, transformation across Indigenous health systems, and to also be a tech startup founder with my brother 𝐒𝐂𝐂𝐂𝐂. And what Safe Space does is we collect experiences of harm and waste within racialized communities, and we have projects in BC and Ontario. And all of that has really helped to hone what I hope is a distilled explanation of how change within systems actually works. And I don't think that this is necessarily restrained to just the area of EDI, but as you move forward, the initiatives that I hope many of you are either a part of or planning after this presentation, hopefully it provides you a bit of information about how to actually go about doing that. On the very far right of the screen is a picture of me and my mom. This is the very first day that I was officially a doctor in a hospital. I had graduated high school. This was my first day of residency at Regina General. And my mom, as she always does, showed up with Subway, and we had lunch together. And for the first time in my memory before that, she actually sat down and started talking about her experiences within health systems. And as part of it, she talked about how she was often afraid to go and pursue care. And as part of that, she kind of convinced herself, and I still see it from time to time, that, if you just stay at home and you kind of deal with it yourself, you don't actually have to expose yourself to those environments. And I think the stories that we've heard from the past presenters, they're real. I see it with my own mom, my brothers, and my sister. I've experienced it myself, and with my 4 children. These are real things that impact real access to care and the experiences of people as they go through it. And so there's many, many reasons why this is important. But hopefully, as we go through this presentation, you'll understand a little bit more about how to move forward the change. So today's discussion, we'll talk about 2 models of social innovation, one of which I assume a lot of us are going to be very familiar with. We'll talk about the patterns within these models, talk a bit about getting trapped in performative change, and I'll explain what that means, and then discuss a little bit about what we can actually do about the change that we're all hoping to achieve. So this is what most of us call social innovation. We have a project or a change that we want to see within the healthcare system. So the first thing we do is we establish a committee. And in that committee, we recruit leaders within the field, persons who have not just clinical gravitas, but also leadership and political gravitas. In that group, we generate a framework. We take that framework out to, different stakeholder groups, people we think can be champions for the change that we're looking for. We validate the things that we talked about around the committee, and then we take that and we start to write a bit of a report. And that report contains things that, are a mix of calls to action, education, cutting edge research, thought leadership at the time. And we take that report and we take it out as a draft, and we ask for organizations to sign on and, let us know whether we're on the right track. We finalize that report. And then we get to the end, which is really to promote calls to action. And we dedicate significant resources to both digital and print media, as well as going out and trying to raise awareness about the changes that we want to see. Now, the biggest challenge with this model of social innovation is a lot of times it just doesn't work. There are multiple reports that sit on shelves telling us what we should have done, but not really moving us to the change that we know we need to have. And so this is an alternative model of social innovation that I've shared in the past, and it's a variation on something called the 𝐒𝐂𝐑𝐈𝐁𝐄 change curve. And what the 𝐒𝐂𝐑𝐈𝐁 change curve looks at is what are the emotions that people need to go through as they move forward change within an organization. And so at the very beginning, you have the status quo, which is kind of your starting point, your norm within your organization or your environment. Something sparks a change. You go through a couple levels of people pushing back for different reasons. And then if you're able to get past that, you start to have the organization really explore whether or not to move forward and commit to the change that needs to happen. So to provide a little bit more detail about this, I'm going to relabel these things because I think that the 𝐒𝐂𝐑𝐈𝐁 change curve, while very good, doesn't always explain it in the frame of EDI. So when you have a norm, there's something that happens within EDI that really triggers people to pay attention to what's going on. And I'll call that a trigger event. And, as we describe each one of these things, trigger events are either a stressor or a set of stressors that make people believe that a change is needed to occur. And previous presenters have talked about, situations of racism, Brian Sinclair, Joyce 𝐒𝐂𝐂𝐑𝐈𝐁𝐄 when she died and live streamed on Facebook, her experience within a Quebec emergency room and the racialized care that she received there. Breakthrough stories about persons from not just racialized backgrounds, but, experiences of Islamophobia, homophobia, transphobia, persons who experience, oppression because of the way that they look, their socioeconomic status, not having English as their first language. These things eventually make their way into the news. And we all sit back and we say to ourselves, we really need to pay attention and consider whether or not we should change. These trigger events can also be within the realm of fiscal changes, changes in budgets, either increases or decreases. They could be due to new political parties that come into power and have different priorities, as well as other policy changes that may be moved forward due to national advocacy, new standards of care or new ways of educating residents. And so as you get through those trigger events, you move towards addressing biases and beliefs. And this is the denial phase within the 𝐒𝐂𝐑𝐈𝐁 change curve. And the bias and belief stage is really the place where you start to get this unconscious pushback against what you're trying to do. And most times this tends to be somewhat disorganized. People sometimes aren't aware of what they're doing, but there's something about the change that conflicts with the way that they see the world, that is abnormal as far as the places that they see people being and the places that they see people making change. Now, if you get past the bias and belief and that internal conflict that often happens, that unconscious pushback, you then move into a stage called resistance, where it becomes a conscious pushback because people realize, oh, well, if this change actually happens, that's going to change the way that I live. That's going to change the way that I work. And so it tends to be a much more organized resistance where people don't want things to change because they want to protect the way that their life is right now. Now, if you get past bias and belief and resistance, you get then to exploration, which is really a structural change where change has now become obligatory and we have to figure out. And then the fallout from all of this, which is really the commitment phase where people start to realize that the change is here to stay and start to contextualize, is there benefits? What are the risks? And how do I see myself as I move forward through this? So just going back to the model again, once you have that trigger event, and I'll use British Columbia as a good example. So recently they had provincial-wide exploration of racism that was triggered by the realization that acute care services were playing something called the drinking game. And what the drinking game was that an Indigenous person would come into an emergency room or come into an EMS, and people would bet to try and guess what their blood alcohol level was. And sometimes people would bet money. Sometimes people would bet coffee. Sometimes people would just bet for fun. But this was pretty widespread throughout BC. And as we all know, presenting with slurred speech, altered level of consciousness, inability to follow commands, I mean, that can be a variety of different things. That could be, using too much alcohol. It could also be a stroke. It could also be a heart attack. It could be a lot of different things. And so when persons realized that this was all going on, it triggered a series of events that then led to an inquest. And that inquest gathered, a group of leaders. Those leaders put together a draft framework. That draft framework went out and collected information, experiences of individuals. As a result of collecting those experiences, they then moved forward with, publishing a report with a set of recommendations and calls to action. And if you watch what happened in BC, a lot of the momentum behind that original report and what triggered those events has somewhat waned. And when you look at the response within BC health systems, there is a variety of different things that come out within bias and belief and the resistance part that really caused a significant amount of pushback towards the change that was happening, and really slowed down the momentum behind the things that at one time everyone felt just needed to happen. And so this brings us to the concept of performative change. And performative change is something that you'll probably hear about more and more. And it's the idea that change is of the type that only allocates just enough resources to de-escalate whatever is stressing the system. If you have a trigger to have people explore, issues within equity, diversity, and inclusion, for example, inequitable pay between men and women who practice in medicine. And this is well studied and well established. I think it's factual at this point that women in general get paid less than men. That has very little to do with the biases and beliefs we often project onto women and how hard they work, how often they work, how dedicated they are to working, et cetera, as a way to justify, the inequity. But the performative change provides just enough resources to acknowledge that exists, but not enough to actually get past the bias and belief or the second part of resistance to get to the point where you're actually having people explore the change. Performative change is also a way to delay momentum until the stressors start to wane, attention starts to be directed elsewhere, and new stressors arise and new priorities arise. And so people often get trapped within this cycle where they have a status quo that they know can't remain, but with each subsequent stressor and then exploration within bias and belief that they try and move through, and then the organized resistance and navigation to try and get through that, immediately just makes them jump back to status quo. And these cycles actually go on over and over again. And if you want to use a non-EDI example, if you look at the response of governments towards the subsequent waves of COVID, every time that a wave starts to kind of wane, all of the things that we were trying to change structurally, the things that we knew worked with addressing the pandemic, those resources tend to wane until they completely disappear. And we jump back to the status quo as if nothing had happened before. And so this is not just a cycle that applies to EDI, it's actually just a part of system transformation. And so what can we do to avoid getting trapped in performative change? And I think more and more, this is the question that I'm being asked by persons who are trying to lead EDI initiatives across the country. And my advice to them comes down to three things. The first is, with the stressors, you have to have a strategy around how to amplify them. And you have to be aware of how people de-escalate those stressors. The second is that with bias and belief, you really have to unpack the underlying beliefs that are behind the biases that persons project onto each other. And the third is that you have to acknowledge and mitigate changes that most people likely don't want, but need to happen. And so systems are designed to manage and minimize stressors. Some of the ways that they do this is through dismissal. You probably heard in advocating for EDI, the statement, this isn't a problem here. This is a problem elsewhere. Its close relative is, if only we did more research, we'd actually understand whether or not this is a problem that we need to handle. And that leads to many more months of actually not addressing the issue. The second is appropriation. You take a stressor or a problem that someone has within the area of equity, diversity, and inclusion, and very quickly it turns around that, well, everybody has a problem with, people being mean. Everybody has a problem with, bad behavior within, different acute care settings. And by generalizing the problem and diluting it across different areas, you actually have the issue appropriated by different individuals. The third common way is that people often shift the burden of change onto the shoulders of those who are actually experiencing the stress. And so different ways that happens is people are asked, you need to tell us how to change, even though it's very clear that certain resources or, decision-making areas just need to be redistributed in a different way. Being asked to navigate and work your way through systems that aren't necessarily friendly to EDI. And then the final common way is shifting risk. And so in the course of bringing up these issues, it's very common for people to be labeled disruptive, not a team player, as well as other descriptions. And so stressors have both benefits and risks, and de-escalating stressors before structural changes rarely leads to shifts in status quo. And these are the real two, these are the take-home messages from this slide, in that when you're talking and looking at stressors, realize that there's always good and bad parts to every stressor. One of the bad parts of stressors for persons who need to change when it comes to racism is that being called racist and re-exploring your identity is a very painful process. But there is a benefit. If you don't have racism within an environment, it's actually very low stress, and high trust. It's a more enjoyable environment for everyone. When it comes to bias and belief, this part is really more about how we see ourselves and not those around us. And I think sometimes when we're talking about bias and belief, we talk a lot about educating ourselves about the people that we aren't familiar with, educating ourselves about the other, instead of looking inside and figuring out why we actually other those people in the first place. Marnie did a really great description of bias. I'll use a bit more distilled term, which is just applying distortions to the world. Bias is really when you project onto someone else something about the world that probably isn't true. Discrimination is when you project that bias onto another person based on race, gender, age, income, culture, etc. And the isms are really differentiated from discrimination when they're coupled with a real or threatened loss of opportunity to a real or intangible resource. So when you have an opportunity to make a choice taken away from you because of racism, projected bias based on the way that you look or talk or your culture, that's what makes it an ism, is that people lose something. And I think that's really important to differentiate between discrimination and the isms, because the isms are really about loss. And that's why it's so important for us to correct them. So expect a visceral, uncoordinated response at this stage as you help people kind of work through their biases. Core beliefs are really being challenged, and that has consequences for how we see ourselves as people and organizations. And be very cognizant that harmony isn't necessarily a good thing in this space. If you have harmony and groupthink, I actually see these as red flags as you're working through bias and discrimination, because people have not gotten to the point where they actually see how their bias gets expressed, and they may not necessarily see how changing their bias will make a difference. There's a lot of conflict at this stage, but that's a part of the process of actually unwinding this. So resistance, as I mentioned before, is a more organized pushback to change. And this is really because it changes who owns the resources, quote unquote. And these resources are more than just budgets. They also include physical spaces, consumables, final say in how people act and are evaluated, information, influence, reputation, among many, many other things. The real reason why oppressive power structures persist, the reason why the isms are still so common among different parts of our society is because these structures transfer resources from one place to another, from individuals and groups to other individuals or groups. And it's very hard to just take these things away and redistribute them in a more equitable way. So resistance is really about negotiation. But in order to negotiate, you have to have truth that these resources are not being distributed in an equitable way. Understand the underlying narratives that justify why people act in these ways, and then talk through how things need to change in the future and have people start to buy in that this change is not only necessary, but that they'll help to move it forward. So just going back to the curve again, the triggering event, the stressor, is really your momentum to move yourself past the bias, the belief, and the negotiating of how change needs to happen. And in the course of riding this momentum, you're actually creating new stories and renegotiating the way that resources are distributed across a system. Once you reach structural changes, that's really the end point to a lot of this EDI work. So once you can structurally change the way that decisions are made, resources are allocated, actually have money moved into certain accounts and teams and other things, hire people, give them the freedom to move forward with this work, then you can start to have confidence that this pattern of change has actually reached a point where it's going to have some sort of impact. So one of the questions I often get is, what is the Canadian Medical Association doing? And I'll just share really quickly about how we're trying to move beyond performative change. So one of the things is amplifying stressors through advocacy. One of the things that the CMA has done in recent history is it's becoming much more bold and vocal and timely in our communication and position statements, as well as our strategic objectives. We're really treating EDI as a core principle, which means that within our strategic mission and across governance and operations, it's something that we consider in every single situation. We're shifting resources, having IPAC funded with $1 million. So the Indigenous Physicians Association of Canada receiving $1 million grant from the CMA Foundation. The CMA funded the filming and distribution of a feature film, first time that the CMA has ever done this in its history, focused on racialized experiences of care among Indigenous peoples. Moving these resources, and we're finding new projects every day, is a way that we're moving beyond performative change. And then the final one I'll mention is really working towards persistent change in how the CMA works. And part of this is something that we need to engage our own members and physicians across the country around, but changing the way that our own governance and our own structures work, and then making sure that individuals who come from those backgrounds, who have that lived experience, actually inhabit those spaces. So this is just a bit of media behind what we've been moving forward. And just in summary, the advice that I have for you as you move forward this change in your own spheres is to really be careful about choosing your model. The first model, the one that we usually use, is really effective when we're making business cases with an organization that's already committed to EDI. But when we're looking at broad change, or we need to have external change happen in order to pressure our organizations to actually change, often the second model, the one based off the Kubler-Ross change curve, is much more effective. The second is that you understand the patterns, that way you can leverage that knowledge into pushing forward the change. And never ever forget that your stressors are extremely important in making sure that the momentum is maintained. Take the time to differentiate between performative change, use some of these strategies to not get trapped. And at the end, it's really about amplifying stressors, leaning into the discomfort, negotiating ownership, and changing the world. Really, those of you who are here today are the change that you've been waiting for. And so having the skills and tools that you need to move things forward, I think, is really important in achieving that end state of EDI across the health system. Changing health systems really means changing ourselves and each other. And I hope that as we move into the Q&A, we can answer some of the other questions that you might have. So thank you very much.